Dear friends, I am happy to share my experiences with you. This is an intumescent cataract. The main incision is being given at around 11 o'clock. This is a complete unedited surgery. Here it goes at around 11:30 o'clock. The main incision is given. Now one side port is made. Here one side port is being made at around 1:30 o'clock. This is the left eye of the patient. Now a big air bubble is injected into the antechamber, and triband blue dye is used to stain the anterior lens capsule. I prefer to stain the anterior lens capsule underneath an air bubble. The dye is washed out with a direct Simcoe cannula. Now, viscoelastic substance is injected into the antechamber. This is 2% hydroxypropyl methyl cellulose. One more side port is made. Here it is being made at around 1:30 or 8:30 o'clock. Now capsulorhexis is a bit challenging in cases of intumescent cataract. Here it is what I do. I make an incision right at the center and make a flap like this. Then I take ureter forceps and I do a very small rhexis. I call it a mini rhexis. In such cases, I do rhexis twice. I do mini rhexis and then aspirate some superficial lens matter to decrease the intralenticular pressure. This is a direct Simcoe cannula being used to aspirate some superficial lens matter. This is loose. There is no adhesion between the capsule and the lens matter, so the nucleus is rotating. Now, once this is done, viscoelastic substance is again used to deepen the antechamber, used over the surface of the cornea to have a better clear view. Now an incision has been given at around 8 o'clock, and with the help of an ureter forceps an optimum sized capsulorhexis will be done. The size of this rhexis will be about 5.25 millimeter, the diameter of the rhexis. This is a bigger CCC. Now the case is ready for nucleus management. I use Appasamis Galaxy CV on machine at present. The tip of the phaco handpiece is embedded and it is chopped. Setting at this time is phaco power 50, vacuum 190 and flow rate 40. I chop the nucleus into several fragments and each fragment is emulsified and aspirated. Emulsified into very fine small pieces and it is sucked out of the eye. So the nucleus is removed and there is no epinucleus in this case. I just have to remove the cortical fibers that is there in this case. Direct Simcoe cannula is again taken and the cortical matter, very soft peripheral fibers of the lens is removed. The undersurface of the anterior capsular rim is polished a bit. There is no cells sticking to the posterior capsule in this case. Now viscoelastic substance is injected into the anterior chamber and the IOL is implanted in the capsular bag. This is the IOL. The IOL is placed over the cartridge and the lens is folded inside the cartridge like this. Care is taken not to entangle the haptics inside the lumen of the cartridge. Now this is the time for implantation of the IOL inside the eye. Here it goes. The leading haptic goes inside the capsular bag and the trailing haptic is also dialed into the capsular bag. Now it is time for aspiration of the viscoelastic substance from the anterior chamber. Direct Simcoe cannula is initially taken for preliminary wash out of the viscoelastic substance. A bit of polishing of the undersurface of the anterior capsular ring and some cortical fibers are probably there. It is being managed. This is done. Now bimanual irrigation aspiration system is taken and it is used to remove some more viscoelastic substance from the anterior chamber. Moxifloxacin is given inside the eye. The side ports are hydrated. And a final wash is given with balanced salt solution. I do the surgery with ringa lactate and I do the final wash with balanced salt solution. Thus the surgery becomes economical. BSS is about 5 times costlier than ringa lactate. Here it is. Thank you very much for watching the video.